you know about a lot of things like when you're using existing drugs. Now, one great, and I love the sort of which is repurposing of drugs. That's when you already have drugs which could be significantly used for treating COVID-19. And one of the drugs was remdesivir. Now, it was actually discovered to treat Ebola, which was by far a much has got a mortality rate as high as 50%. That's what I've heard. And that, if you correct me, that is like really very high mortality rate. Now, for sex. Now, you also had now the problem here is like the Americans and even the earlier Chinese were very positive of remdesivir. The Americans call it Veklury, that's the name, and they had 3 randomized controlled trials, and we'll come to that at a bit to understand what randomized controlled trials are also. And they found it to be safe for adults which are 12 and above weight of 40 kgs. In the solidarity test was done to find out how effective remdesivir. It was found that it is no longer that effective, as a matter of fact, and which made WHO to remove it as one of the recommended drugs, if I'm correct. Contradictory studies coming in over a period of time is because as the data increased, the test was done maybe after, or maybe had an elongated time more than the American test, and you kept on getting data from around the world, and that changed. So this, I just wanted to know if you could throw some light on this.
So we know that SARS-CoV-2 is a new virus. There were no proven medicine or treatment available against the SARS-CoV-2. So some of the experts in the beginning thought that let's try whichever medication works. So remdesivir is known to reduce the replication of the virus. And with some of the early findings, some of the early studies from France and China also, there were indications that it can help in reducing the progression of disease to the next level. But those were the early stage, small scale studies, which gave a good indication. But we know, as an example, somebody who see a clinician who is treating 15 patients or 50 patients, and if he use remdesivir, it's difficult to say whether the benefit was due to remdesivir or those patients would have recovered without remdesivir. So that's what happened. Individual practitioners who were seeing patients and they were prescribing remdesivir, they often reported that this outcome is really good. But we know that science or medical sciences should be evidence-based. And one of the best tests to test the efficacy or effectiveness of any medication is a randomized control trial. And more so large-scale randomized control trial. Like one side you have a 10 or 15 or 50 or 100 patient with somebody seeing. Other side you want to go for thousands of patients, 10,000, 20,000, 30,000. And in that kind of setup, you can get a better picture whether the drug is really working or it's an artifact. So Solidarity trial was a multi-country trial which had a large number of patients enrolled. And when it was examined, the findings of Solidarity trial, it was found that the drug is not effective. And that's when the World Health Organization and other international agencies said that remdesivir is not effective. So individual opinion are always variable and differ from one individual to another individual. The gold standard in such process is randomized control trial. Now, let me quickly, 1 minute, reflect on randomized control trial. What is done in randomized control trials, which should ideally be done double-blinded, which essentially means the person who is giving the medication is not aware what treatment is being given. And individual is not aware because he or she does not also know what treatment he or she has received. He might have received, for example, the remdesivir or a placebo.
Yeah, now we need to sort of add to the audience just sort of, we are talking about here, we are taking a group, double-blind experiment is like nobody knows, neither the doctor, neither the audience who's, or you can say the people who are under this controlled trials. So there are 2 types of treatment given. One is the original treatment, which is effectively the treatment. And second is what Dr. Chandrakant talked about is placebo, which is a false treatment. So nobody knows who's actually undergoing the treatment and who's undergoing. This is just to remove any bias. So thanks a lot, which you have brought in. This is about interventions. This is to find a counterfactual and factual. This is sort of one of the most important techniques now being used in social impact evaluation. And it's actually started from clinical trials. Thanks a lot, Dr. Chandrakant. You could go ahead.
This is the gold standard in doing blinded for both sides, so nobody is biased. Because if a provider or the doctor is aware that which medication is given, it is very likely that they might be biased to give to somebody who is likely to recover, or maybe biased to give somebody who is not give somebody who is unlikely to recover. So it's completely kept blind, and only at the stage, a particular fixed number of cases which need to be enrolled and followed up, then only the trial findings are opened up. And then experts, individual expert or independent expert independently look at it, the data, and analyze that before arriving on the conclusion. So it removes all kind of biases, or as many biases as possible are removed. And that is really valuable and independent advice. Otherwise, people will argue that no, this worked, this did not work. So, and they look very objectively on the predefined parameters. The trials have an advantage of a predefined protocol, which is followed irrespective of the outcome. And then once the trial is completed, then you know that whether it works or not works, and people need to take that on as a final outcome. Of course, you can do a more large-scale study. So that's what was found on remdesivir. And many other drugs, and that's how dexamethasone, which is such a low-cost drug, was found effective through a recovery trial, which noted that this drug has a particular reduction in hospitalization and mortality benefit. While the dexamethasone is an age-old medication, widely known and really low-cost and cheap, available across the world in India.
That was my next question, and good you talked about. But before I go to that, just here so that then the audience gets clear, when the experimentation is being done, somebody knows whether it's a placebo or a treatment. Now, this is another entity. So there's another entity involved, which is doing the experiment, which knows who has got what, but the doctors who actually are going to be analyzing the data and the subject matter, or the people who you can say trial, they are not aware of it. Am I correct?
No, nobody knows actually. So theoretically, what is done, usually in the good large-scale trials, there is a coding given to each of the samples. So the packaging should always appear very similar. Mm-hmm. So they are packaged or similar, done very similar packaging, and there is a code on that medication which should be given. Now, what usually as an investigator are supposed to do, they need to run through an identified method, pick a number from the list, and then whatever number is picked, that relevant linked package need to be taken and opened. And so they don't really know. Even the packagers do not know, but of course, somewhere in the system, in that packaging, the record is maintained that the number XYZ which were given is what, and that process is called unblinding. When that kind of thing, somebody becomes sick and a particular outcome is seen or die in that particular scenario. So for that person, the medication number which was given or code which was given to that drug, which the person received, is unblinded, and that is computer generated system. The record is kept there, and unless that is opened, that what was that drug or medication given to that individual, nobody really knows. Everything is computerized and this way. So it's really fascinating and interesting.
This is fascinating because somebody makes it, you have a system, and another entity or an actor is giving, it's like an organization is coming, it's carrying on, you have then another set of actors, doctors or researchers would be coming in, and then the people. Now, this entity also does not know, but they have a coded system wherein they have okay, this particular treatment or this particular, let's say if it's an injection which you're going to be giving in, this particular dose is actually the right. So it's like the true and false, 1 or 0, binary, it's how it's mapped. And then at the end of the trial, they come out. Maybe there's an Excel sheet or a sort of a data where they match who got what.
Yeah, so that's how it is. Like, for example, so in the vaccine trials, one individual get a vaccine. For example, in the drugs, it's far easier. You can give a placebo. Like, for example, a medication is given, similar packaging can be done of paracetamol, which is like for fever, but you can administer, or even chalk powder can be used, placebo. But in vaccine trials, usually you need to give an injection, and now you don't want to give an injection of saline or water. So many of the participants in the vaccine trials usually receive meningococcal vaccine, which is a proven safe and effective vaccine. So the person who is receiving an actual vaccine under trial, and then other person who is in the control arm, is likely to receive some other vaccine, which is not the same vaccine, but a very different vaccine. I know, some of the trials, the meningococcal vaccine was given to the control arm. So the people who did not receive COVID-19 candidate vaccine received a meningococcal vaccine, which prevent against meningococcal meningitis.
So I have a very good question. That's a very thought-provoking question. but this is very interesting. Let's say I'm within a trial and I get the dose. I get a vaccine, but it's a placebo. Don't you think a lot of times the power of the mind comes in, that even both the treatment and the placebo, they know that, okay, they think actually that they have got the vaccine, all of them. And that might just, the power of the mind might just distort a bit of trust. Maybe without those trial, they might have done much more poorly against disease or something.
Oh, but definitely, that's how it is. Like, it's a widely proven placebo effect that what they did, many of the researchers did, and on many different aspects. So, for example, somebody who has fever, they were given paracetamol for fever, and then other people who did not have, who had fever, similar group, but they were given chocolate powder, the chalk powder. Now, studies have found that simply giving like completely ineffective medication, 30% of people will still recover from that, because that's how your belief and your immune system starts. So that is called placebo effect. If people are simply told that they have been given medication, obviously, unless the situation is really complicated, in common conditions, they recover. Their healing power starts. So that's what happens. Even in the vaccine, that's why you require, because that effect, when we do randomized control trial, the both sides should, we would assume that in the both sides, people will think that somebody who received vaccine would think that they might not have received vaccine, and there would be people on the control arm, they would think they received vaccine, and both sides, it will nullify on both sides.
Yeah, true. You have articulated the concept where you talked about, of course, recovery. Recovery is randomized evaluation of COVID-19 therapy. Talk about dexamethasone, but there is another thing which is methylprednisolone, which is also was one of the drugs or steroids, which are very helpful. Now, when you're talking about these two drugs, especially methylprednisolone, when you're talking about, do talk about when you're talking about steroids, because steroids could also have a harmful effect. They have to be given at the right point in time. That is what. So if you could elaborate about these two, how effective they are, their efficacy in curing exactly COVID-19, but at least delaying it. Or
so now we have developed a little better understanding of how SARS-CoV-2 progress in human body. And we say that first 7 days are viral phase, which essentially means that the virus multiply in human body in the first 7 days. And then next 7 days are usually immune phase, in which our immune system starts reacting, responding to it. Now, we know that in second phase, especially moderate illness and severe illness, when our immune system is trying to cope up with the virus, sometimes it overreacts. And then when it overreacts, it's called cytokine storm. A number of people who develop severe disease die due to cytokine storm. Now, cytokine storm, in the simple terms, is like if we know that there are police standing at the security at the public places due to any threat and apprehension. Now, their role is just to, if there is some element, like, for example, a terrorist appear, then they should try to eliminate terrorists.
Yeah, right.
But sometimes what happens if there are many more terrorists and then police start indiscriminate firing on the street, then of course some of the people, antisocial element terrorists might die, but also some citizens will die. And that's what exactly the cytokine storm is. Our immune system's role is to identify the foreign objects and try to neutralize and kill them. But when our immune system starts thinking that it's beyond my power, I am not able to control this virus replication, so it becomes brings all the firepower and start indiscriminately releasing everything. In that process, what happens? Of course, virus die, but also start damaging our own body organs, and that is called cytokine storm. The word itself is cytokine storm.
Okay.
That excessive release of protective immune things, which will harm the virus or damage this thing. So second phase is really crucial, and we want to a number of mortality, a part of mortality due to cytokine storm. So that it is that stage when corticosteroids are recommended for treatment. Only when in those individuals who are hospitalized, who require medical oxygen, because then the role of steroid is to reduce, to moderate the immune response. Like they weaken the immune system, so our system does not become overreactive and responding to the virus. So that's the role of this thing. Steroids are not required and not recommended in the early phase or when virus is multiplying. Because if virus multiplication stage steroids start, we give steroid, then our immune system will weaken and virus will multiply faster, and then the disease could become severe. So only at the immune stage where our immune system is overreacting, that time should be given. So scientists have found a very methodological approach, when is the right time to give steroids, and that's the right way of doing it. So dexamethasone is one, but methylprednisolone is other one. They are recommended like any of based upon the clinician's preference, but usually they fall in the same category. They work in a similar fashion.
Put it in a layman's term, if I give these steroids at early stage, they might just be attacking cells, or might be protecting you. So that's because it comes as a specialist drug, and like a commando force. And when the commando force is in much before, when you really don't need that particular force. So